Hello everyone and welcome to the December webinar. Today we are going to be talking about the physician fee schedule and other new Medicare rules for 2016. I will be presenting with my colleagues Steve Beck, Pari Magera, and Marguerite Amin. Before we dive into the new rules that we'll be discussing today, I have a few housekeeping matters. If you have any questions throughout the course of the webinar, you can always type the questions in the chat box and we will try to save time at the very end of the webinar to answer your questions. And then the only other item I wanted to mention is that next month's January webinar will be on January 13th, and this will be titled Corporate Healthcare Deals. Katie Douglas and Ryan Johnson from the Healthcare Group will talk about key strategic issues to consider and common pitfalls to avoid when structuring healthcare transactions. So please join us for that webinar next month, and I think we are ready to dive right in. So our agenda for today, we're going to start by talking about the 2016 Medicare physician fee schedule with a brief overview, and then diving right into some of the substantive details, including updates to the Stark Law, telehealth expansion, advanced care planning, chronic care management services, a clarification to Incident 2 billing requirements, an update to the physician quality reporting system. We'll cover value-based payment modifier and misvalued code changes, and then we're going to move into some provisions from the Budget Act that made changes to the provider-based requirements, and then touch on two midnight rule changes from the OPPS for 2016. So our first topic today is a big one. It's the physician fee schedule for 2016. And we do this talk every year, but it's always important to note that this is probably the hardest talk we give and the most difficult webinar to do because there is so much content covered in the physician fee schedule. There's just the physician fee schedule covers a lot of ground. Some things will be really, really important to some members of the audience, but not so important to others. And we have to cover as much as we can in the 50 or 55 minutes that we have with you today. So these are just very kind of high-level summaries of substantive changes that we think you will find important. And we are always happy to follow up if you have any more specific questions or need more detailed answers to some of the topics that we cover today. But really, I think the most important thing to note is that the fee schedule, it covers a lot of ground, but there's a lot of commentary from CMS, and it hints at CMS's thinking in a lot of interesting ways. So we try and pick up on that as we're reading through and digesting the content for you today. So with that background, I will let my colleague Steve Beck talk a little bit about the Stark update and some other important changes in the fee schedule.
Thanks, Catherine London, for that lovely introduction. I want to set the stage a little bit for this fee schedule because this is the year in which the sustainable growth rate provisions of Medicare were finally eliminated. And everyone in the audience, I'm sure, is aware that what we have had for, I don't know how many years, probably 15 plus years, has been a system where the law provided that there could be no increase to the physician fee schedule beyond something that was limited by formula, and that formula was the sustainable growth rate. And so every year, people would come out in October, November, December and say, well, next year the sustainable growth rate will require a cut to physician payments, and it would often be a cut that would be like 20% or 15%. And then each year at the very end of the year, or increasingly right after the end of the year as the budget deal got struck, we would have what was called the doc fix. And the doc fix would say, well, we're going to lay over the SGR for yet another year and go forward with what was in effect a reasonable increase in rates for physicians. And people have thought for a long time that this process was bothersome and ultimately might prove to be problematic for physicians if the government failed to do the doc fix one year, or if they decided that they would do the doc fix, but the fix would not create a reasonable increase. So that became a thorn in the side of Congress, a thorn in the side of the budgeters and the government for many years, and it required a lot of lobbying from physicians and physician advocacy groups. And this year we had a repeal of the SGR, and as might have been predicted, the repeal of the SGR probably hurts physicians. And the reason I say that is that the SGR repeal had to be paid for by something, and it was paid for by a number of things, at least partially. Some of them were reductions in hospital reimbursement. Some other reimbursement categories or savings provisions that were created. But maybe the most important thing was the new law puts in place very limited increases in physician fee schedule increases over the next long period of time. So for up through 2019, increases are supposed to be 0.5% per year. That's a low number. They're then frozen completely from 2020 to 2025, assuming that there isn't a legislative change. And then incentive programs are created that have potentially a significant effect on physician compensation. And we're seeing this in lots of different areas where people are struggling to create some kind of value-based or incentive-based payment system that doesn't eliminate physicians, doesn't make it impossible to continue some of the businesses that exist currently, but that change the way people behave. So you'll hear a little bit more about the two avenues that have been created by the SGR repeal later in this talk. They are talked about as MIPS and APM. So MIPS is the merit-based incentive payment system. It's a value incentive. If you are in the MIPS system, then in later years, your increase under the physician fee schedule is increased by another 0.25%. The other track, and you have to opt into it, is the alternative payment models. We don't really fully know what those are. If you're in those, if you opt in, you get another increase in the physician fee schedule that's another 0.5% per year. But we are going to be facing probably a long period of time in which increases in fees are very modest, and it is certainly likely that we'll see commercial payers that will follow and try to create very modest increases for physicians. And this will, of course, put new pressures on the system, and the pressures will be similar to some of the pressures we've seen. Doctors looking for sort of a larger model, either inside a hospital organization or inside a very large clinic organization, to give them the ability to gain efficiencies and perhaps be able to demonstrate that they deserve a larger payment from commercial payers. And also doctors looking for other services to deliver besides the normal services that they've delivered for years that are direct physician services, procedures and evaluation and management services. So we're going to see businesses diversifying, and there are lots of different ways that that's going to happen, and we're going to see more consolidation in the marketplace. That's a little bit of an introduction to the kind of the scope of the physician fee schedule this year. The other thing that is sort of big is that we have some updates to the Stark regulations, and we haven't had those very often. Sometimes we get them from the physician fee schedule. Sometimes we get them in other sets of regulations. This includes some material clarifications, a couple of new exceptions that will actually, I think, be used by people significantly, and then a lot of language cleanup that as you read through it, you don't understand what difference it makes. It doesn't make any. But I'm going to talk about really, let's say, three things. Well, I'll say four things. And and they're all fairly brief, but some of them are significant. First, lots of people over the years have had this problem that they have a deal that they've created and they never got it signed. And having a failure of signature meant that they were in violation of the Stark law, which meant that they had to notify the government that they were in violation and hope that the government would waive a penalty. And the penalties, as we all know, are enormous for Stark rule violations. This is a small change. There's a small change and a bigger change for arrangements that just violate the signature requirement. So that means you didn't have a signed agreement and it lapsed. You had an agreement and you never signed it. There was a prior provision that said, well, if it is inadvertent, we'll give you 90 days. If it's not inadvertent, we'll give you only 30 days to correct the problem. It's hard to tell exactly what not inadvertent failure to sign means. And I think the government maybe understands that. I think they also maybe don't love the fact that people have got a violation that comes from something that really wasn't intended to be a violation. They were trying to get the thing together and they failed as a clerical matter to sign it. So the new rule extends to all failures to sign, not just the inadvertent ones, 90 days. Now 90 days often doesn't help you because if you fail to sign, you discover it a year later, not 90 days later. But it's better than it was. Holdover leases, this is bigger, and it's kind of similar. It at least is in the same area. What happens is you sign a lease with somebody, and you are in a Stark exception because it's a fair market value lease that meets all the other requirements, and the lease provides that it expires. And 3 years later, the lease expires, and you discover 5 years later that for 2 years, you've been operating on an expired lease. And what you've been doing is you've been paying under the lease and it's been a holdover. And most people sort of out in the normal leasing world have holdover leases that go forward on sort of a month-to-month basis. Here, there was a prior rule, and the prior rule said you can have a holdover lease and it has to be done within 6 months. It was another one of these time limits. So when you discovered that you had failed to notice that the lease expired and you discover it 2 years later, you've got a big problem because you only had holdover leases for a 6-month period. So this is a significant change. They eliminated the 6-month requirement. They said, we'll allow a holdover lease that goes beyond 6 months. Now, to be clear, the thing needed to be within the exception in the first place. So you had to have a holdover lease that met the requirements in the first place. And importantly, important thing number 2, you can't change the way the payment mechanism works. You can't claim that it's a holdover lease if you've changed the payment system. Third, the holdover lease has to have been in place 1 year, and you know that all of these contracts currently say this will be in place for 1 year and we won't change it except if a year has elapsed. Once you've got a lease that's gone over the 1 year period, you're entitled to have it be a holdover lease, and it can be a holdover lease for a long period of time. So that means compliance people can relax a little bit about these things. It's important to note that this applies to the other similar compensation-only exceptions in Stark. So it's real estate rentals, equipment rentals, personal service arrangements. All of those can be held over for more than 1 year. I'm going to spend a minute to talk about something that is the most salient of the clarifications, just to tell you that most everything else was so trivial that it was impossible to read. This is physician retention payments. And what they said is the old rule seemed to allow you to base the amount of a physician retention payment on the physician's annual income over a period up to 24 months. Now they said, no, it's the annual income averaged over the previous 24-month period. It was just a little mistake, I think. It's a clarification that is not important. A couple things are important, and the first one could be very important. And this is a new exception in the Stark Law. And everybody knows that the Stark Law is a statute, and the statute created the initial exceptions. And when the government wants to create new exceptions, they frequently do it through a regulation, and a regulation is not as big a deal as a statute. And their authority, the government's authority to issue new exceptions and regulations, is very limited. It really requires them to put in place systems that are so protected and conservative that frequently regulatory exceptions are kind of no practical value. Or sometimes they hurt. They actually make something that was more doable less doable because they've created an exception that applies and changes the practice. But this is a regulatory exception that actually provides what I think is some interesting value. And I think a lot of people are going to use it. This first one is assistance to compensate a non-physician practitioner. What they're saying is that if a hospital wants to say to a physician, you hire a non-physician practitioner and we'll pay 50% of that person's compensation for the first 2 years of the arrangement, that's an exception to Stark. That's a pretty neat thing. Now, the non-physician practitioner has to come from outside the geographic area. So we're bringing somebody in who wasn't already practicing in the service area. The non-physician practitioners are PAs, NPs, CNSs, nurse midwives, social workers, psychologists. So pretty wide group of folks. There are a number, this exception goes on for a couple pages. I didn't put everything on the slide. There are a number of requirements. Most of them are not particularly salient. There can't be a condition that the physician refer or that the nurse practitioner refer. The thing can't violate the anti-kickback statute. Well, I assume we would try to make it not violate the anti-kickback statute anyway, so I don't think that's particularly onerous. There can't be any unreasonable practice restrictions. This is similar to the physician recruitment exception. Remember, they used to say you couldn't have a non-compete, and then they made clear that it couldn't be an unreasonable one. Well, you shouldn't be putting unreasonable stuff in anyway. We think all of those things are reasonable that we put in our contract. So I don't think those things are huge obstacles to doing this. The main thing is you can only do one of these every 3 years for a given, it says a given physician. Perhaps it means for a given practice. I would say probably it applies to a physician practice. And there's a small exception for replacements if you hire a person like this and subsidize the acquisition of the person, and then you'll lose him after a year. I expect that just like physician recruitment, where we had a period where almost every clinic went to a hospital and said, help us with physician recruitment, and the help that was permitted by Stark was fairly limited. I think we're going to have lots of clinics going to hospitals and saying, help me to bring in a non-physician practitioner. And I think this is the government's way of saying we're going to try to promote the use of non-physician practitioners. It's trying to eliminate a disincentive that doctor groups may think they have in bringing in non-physician practitioners. Now, I think there are lots of groups that have been very successful at creating a non-physician complement to their physician primary care practice. And I think it's important to say that this is supposed to be primary care primarily. And so I don't know that there's a big disincentive there. But if you can bring in a non-physician practitioner and for 2 years it's at half price, seems like there's a good ability to start that model working, and we're going to see a lot of people asking to do it because the government has said that they can. So that's pretty significant. I'm going to talk about one more thing, and that is timeshare arrangements. I think of this as, which is another regulatory exception, as one that is not particularly significant. What it does is say, if you're entering into an arrangement between a hospital and a doctor group, and it is for sharing of space and equipment and personnel and supplies. You know, you're bringing in and saying, you run a clinic within our clinic space for 1 day a week or something like that. And that's not a lease. If you haven't structured it as a lease, then they must have thought, well, you're not inside the leasehold exception. And so we need to provide a separate exception for you. So they did. And the key is that fourth bullet point, it's a non-possessory interest. That means it's not a lease. So it's just something that looks and sounds and smells kind of like a lease, but isn't. So they've created an exception for it. It looks just like the lease exception and some of the other exceptions. Has all the same requirements, all the same limits on percentage and per unit things. It can't be a sharing of MRI or other advanced imaging. It really just clarifies an area of unclarity in the prior compensation interest exceptions in STAR. All right, I've, as usual, overdone it, so I'm going to let the next person talk, and I'm not sure which person that is. I think it's Catherine London.
Thanks so much, Steve. So the first topic I'm going to cover today is the continued expansion of Medicare coverage for telehealth services. So each year, CMS continues to add to the list of services that are covered by Medicare if provided by telehealth technology. And for 2016, CMS is adding to the list services for prolonged inpatient or observation care, as well as certain services related to home dialysis for patients with end-stage renal disease. So with regard to the prolonged service codes, these are codes that can only be billed in connection with hospital inpatient and skilled nursing facility evaluation and management codes. And so I should note that there are limits on these codes. For instance, I think a limit of 1 subsequent hospital visit every 3 days and 1 subsequent nursing facility visit every 30 days. And CMS in the commentary noted that those limitations would continue to apply when the services are provided by telehealth. So with regard to the ESRD home dialysis codes, I have included on this slide the actual code language. And it's kind of interesting that these are services for home-based dialysis, and a patient's home is not considered an authorized originating site for purposes of Medicare telehealth reimbursement. And as many of you know, Medicare will pay for services provided by telehealth only if the beneficiary is presented from an originating site, which include very specific sites such as hospitals, physicians' offices, FQHCs, and other types of facilities that are located outside of located in a health professional shortage area or outside of a metropolitan statistical area. So CMS is recognizing now that many components of these specific home-based dialysis services could actually be provided at some of these originating sites, and therefore felt it was appropriate to add these services to the list of services that can be provided by telehealth. So the only other change CMS made with regard to telehealth is that certified registered nurse anesthetists are now part of the list of distance site practitioners who can furnish telehealth services, and Medicare will reimburse for these services. So obviously the expansion of Medicare coverage for telehealth continues to be very, very slow. And this is due in large part to the fact that Medicare reimbursement for telehealth remains very, very limited by statutory requirements. So CMS will continue to consider new services that it's willing to pay for if provided by telehealth, but CMS really remains pretty restricted in terms of how much they can change the coverage for telehealth services. The next topic I wanted to address is advanced care planning. So beginning on January 1st, 2016, Medicare will start paying physicians and non-physician practitioners for time spent providing advanced care planning services. And many of you will remember the so-called death panel discussion back in 2009 or so during the enactment of the Affordable Care Act, and this is the return of the death panel with a little bit less debate this time. But starting in 2016, Medicare is going to pay for these advanced care planning discussions between a patient and a practitioner. And I've included on this slide the payment that will be made for these services if provided in a physician's office or a hospital. And then CMS will also provide this kind of add-on payment for additional time spent in consultation for these advanced care planning services. So here's the actual code description, and it's worth noting that this service includes these discussions of advanced directives and standard forms that are completed for these advanced directives, and even includes time spent completing these forms if the patient and practitioner actually spend time together preparing these types of forms. So in order to bill for this code, the practitioner would report the E&M service and one or both of the advanced care planning codes, depending upon the duration of the advanced care planning service. But it's noteworthy that the advanced care planning services do not have to be provided and billed on the same day as the E&M service. They can actually occur on different days. And CMS also clarified that these services can be provided as part of an annual wellness visit or during any routine office visits. So advanced care planning services can be billed by physicians and also non-physician practitioners whose scope of practice include these types of services and who are authorized to independently bill for the services. So this is not limited to a particular specialty, and CMS also indicated that these services can be provided and billed incident to. In the commentary to the final rule, CMS noted that the billing physician or non-physician practitioner who's billing for these services must manage, participate, and meaningfully contribute to the provision of these advanced care planning services, in addition to providing direct supervision if the services are provided incident to. So the final few notes to add on this topic that CMS clarified in the commentary is that any applicable cost-sharing requirements will continue to apply unless the advanced care planning services are provided as part of a Welcome to Medicare visit or an annual wellness visit. For now, these services will not be covered if they're provided by telehealth technology. And then CMS clarified that advanced care planning will be a standalone billable visit for a rural health clinic or federally qualified health center when provided at those facilities and all other requirements are met. So moving on into changes in the fee schedule to payment for chronic care management services. In 2015, CMS began providing a separate payment under the fee schedule for non-face-to-face chronic care management services provided to beneficiaries. And these are services that are provided to patients who have multiple chronic conditions that are expected to last more than a year or until death, and that place patients at a significant risk of death, acute exacerbation, decompensation, or functional decline. These chronic care management or CCM services are not currently included in the payment to rural health clinics and FQHCs, and that is because these facilities don't bill under the fee schedule for their services, and instead RHCs are paid an all-inclusive rate for the services they provide, and FQHCs are paid, used to be paid under a similar methodology, but now have begun transitioning into this new prospective payment system. So CMS has recognized that some of these chronic care management services are being furnished at these facilities, but the facilities aren't receiving compensation or separate compensation for these services. So beginning on January 1st, 2016, these facilities can bill for CCM services that are furnished by or incident to the services of an RHC or FQHC physician, NPPA, or nurse midwife. In order to bill for these services, the practitioner must provide a minimum of 20 minutes of CCM services during any given calendar month. And to meet that 20-minute requirement, the facility can count the time of only one practitioner and can't count any overlapping intervals, such as when two or more practitioners are meeting to discuss a patient's care management. Another important note is that these services also cannot be provided and billed, or cannot be billed during the same 30-day period when other transitional care management services are being billed, or the services that under any other program that provides an additional payment for care management. And CMS seemed to emphasize that fact in its commentary. So the other item that CMS discussed in the final rule is that if these services are provided incident to, direct supervision would be required, but CMS did say that it would consider changing this requirement in future years if these facilities find that requiring direct supervision is a barrier to furnishing chronic care management in RHCs or FQHCs. So I won't go in depth into some of the specific requirements that CMS laid out in the final rule, but there are a number of requirements that a facility needs to meet to bill for these services. So in terms of when the service needs to be initiated, during an annual wellness visit or preventive physical, they have to make sure that there's continuity of care, overall care management for chronic conditions. A patient-centered plan of care needs to be in place and made available to all practitioners at the facility. They need to effectively manage care transitions, coordinate with home and community-based service providers. And then the last couple requirements that I noted on the slide here is that there needs to be secure messaging or some sort of consultation, electronic consultation methods between a patient and caregiver to communicate with the provider. And then finally, patients have to be informed about these services, and they have to provide written agreement to have these services be furnished. So these are just kind of a general overview of some of the changes, and now I will let my colleague Marguerite Amon talk about some additional fee schedule updates.
All right, thanks, Catherine. So first up, I'm going to talk about the clarifications that CMS provided regarding the Instant 2 policy for 2016. So first up, physician billing requirements. CMS proposed a rule that had made quite a few people quite nervous. CMS proposed to remove language that stated that the practitioner supervising the auxiliary personnel need not be the same practitioner upon whose professional service the Instant 2 service is based. So without any additional clarification, many people took this to mean that CMS intended to eliminate the group practice supervision option, which allows any physician member of the group practice to supervise the auxiliary personnel that is furnishing the Instant 2 services. So many people thought CMS was requiring that all three roles, the treating, supervising, and billing of the Instant 2 service, had to be filled by a single practitioner. So there was considerable pushback on this front, and CMS revised the rule to clarify that their intent was actually just to make sure that the supervising practitioner and the billing practitioner are the same person, even though that might not be the same person as the treating physician. The rationale behind this change deals with CMS's longstanding position that the billing practitioners should have a personal role in and responsibility for all services for which they bill. And within the group practice setting, the physician with the greatest responsibility regarding that Instant 2 service is the physician who is directly supervising the service furnished. So the practical implication of this change for most practice groups is just to continue with the status quo, but it is a good reminder to confirm that your current billing practices conform with this clarified requirement. So up on the screen I have the new revised version of the rule, which now says the physician supervising the auxiliary personnel need not be the same physician who is treating the patient more broadly. However, only the supervising physician may bill Medicare for the Instant 2 services. Up next is clarification that they provided for the qualifications of the auxiliary personnel. In the 2014 final rule, CMS required that all Instant 2 services and supplies had to be furnished in accordance with applicable state law. And they also defined auxiliary personnel to make sure that the individual furnishing those services met any applicable requirements under state licensure laws. And now for 2016, they're providing one more intricate clarification, which is that auxiliary personnel cannot have been excluded from Medicare, Medicaid, or other federal healthcare programs, or have had their enrollment revoked for any reason at the time they provide such services or supplies. So again, this is largely just an explicit statement of an already existing policy. All right, on to the PQRS. So just as a quick background, the Physician Quality Reporting System, or PQRS, is a quality reporting program to encourage eligible professionals, referred to as EPs, and group practices to report information on the quality of care to Medicare. PQRS provided incentive payments in the past, but those ended back in 2014. And now they have payment adjustments, which started in 2015 and will continue through 2018. Starting in 2019, however, the adjustments for quality reporting will be made under the merit-based incentive payment system, which Steve mentioned earlier and is referred to as MIPS. So the bulk of the PQRS proposal within the 2016 fee schedule focused on the 2018 payment adjustment, which again will be the final adjustment under the PQRS system. And this will be an adjustment based on the reporting that happens in 2016. So CMS continued its efforts to align the PQRS with other quality reporting programs like the EHR incentive program and the physician value-based payment modifier. Overall, the requirements are consistent with the requirements for 2017. So there's at least a little bit of stability before the switch happens to MIPS in 2019. CMS has set the same criteria for satisfactory reporting that was established for the 2017 payment adjustment, which is generally to require the reporting of 9 measures covering 3 national quality strategy domains. If an EP or group practice does not satisfy this reporting requirement or chooses not to participate in 2016, then a 2% negative payment adjustment will apply to covered professional services in 2018. So all EPs who furnish covered services must participate in the PQRS each year and meet the criteria for satisfactory reporting, or alternatively, they can participate in a qualified clinical data registry. Based on some confusion regarding who must participate in the PQRS, CMS clarified the definition of an eligible professional. So these include physicians, PAs, NPs, CNSs, certified registered nurse anesthetists, nurse midwives, clinical social workers, clinical psychologists, registered dietitians or nutrition professionals, a qualified or a physician occupational therapist or a qualified speech language pathologist, and a qualified audiologist. CMS made changes to the PQRS measure set just in order to add measures where gaps existed. They also eliminated a few measures that were either duplicative or measures that they had replaced with a more robust measure. So there are a total of 281 measures in the PQRS measure set and another 18 measures in the group practice reporting option for 2016. Also, as recently authorized by Congress, CMS is also adding a reporting option that will allow group practices to report quality measured data under the Qualified Clinical Data Registry. All right, now moving on to the physician value-based payment modifier. Under this program, physicians can receive payment incentives for providing high-quality, efficient care. EPs or eligible professionals that underperform then are also subject to a negative payment adjustment. Just like the PQRS, the value-based payment modifier is set to expire in 2018 as MIPS will begin in 2019. So the updates included in the 2016 fee schedule are largely intended to help accommodate a more easy transition from this program to the MIPS program in 2019. So CMS provided some helpful clarification regarding how it identifies groups and solo practitioners subject to the value modifier. And it also explained how it determines the size of a particular group when the analysis of claims data doesn't match the query from the provider enrollment system. So one important clarification for the value modifier, it will for the first time apply to payments for services furnished by physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists. And it'll apply to these practitioners both in group practices and those providers who are solo practitioners. And this is in order to make this consistent with the practitioners who will be responsible under the MIPS system that is coming in 2019. So all group practices and solo practitioners will be subject to either an upward, neutral, or downward adjustment based on the quality tiering methodology, except for the fact that group practices comprise solely of those non-physician practitioners that I just mentioned, or those same practitioners who are solo practitioners will not be subject to the downward adjustments. The maximum downward adjustment will be -4% for groups with 10 or more professionals and -2% for all other groups or solo practitioners. And the maximum upward adjustment will be 4 times an adjustment factor for groups with 10 or more and 2 times an adjustment factor for all other groups and solo practitioners. And again, that adjustment factor is something that's determined at the conclusion or the end of the performance period. All right, my final topic and the final topic of the fee schedule is some updates to the misvalued codes. The misvalued code initiative started back in 2008. The 2016 final rule contains pretty extensive discussion around the specific codes and some broader policy issues. The rule identified several sets of new, potentially misvalued codes, ones that they've identified through various sources, including public nomination, which included 3 codes that were nominated, and an entire subfamily of neurostimulator codes. These were all finalized as potentially misvalued. Also of note is that they actually implemented the high expenditure screen that CMS finalized in 2015. So this flagged codes that account for the majority of spending under the fee schedule. So they reviewed high expenditure services across specialties with Medicare allowed charges of $10 million or more. So these are sort of codes that are flagged just for being very expensive. And they didn't actually run the screen and propose any misvalued codes in the 2015 final rule because of resource constraints. But for this year, they reran the screen and they proposed 118 codes and finalized 103. They did not review any of the global surgery codes because that is happening in a separate revaluation. So then these potentially misvalued codes are reviewed and revalued through notice and comment rulemaking. The revalued codes this year included a reduction in payments for radiation therapy services, as well as changes for the lower gastrointestinal endoscopy code set. And then one thing I want to point out is that in 2014, Congress set targets for the adjustments to misvalued codes that CMS was required to make for calendar years 2016, 2017, and 2018. And they set a 1% target for 2016. So within the 2016 fee schedule, CMS outlined their methodology in order to identify any changes to misvalued codes and also to distinguish between misvalued code adjustments and other RVU adjustments and calculate an overall net reduction. CMS estimates that for 2016, the net savings attributable to the misvalued codes is 0.23%, which falls short of the 1% target. So in order to reach that 1% target, CMS is reducing the conversion factor by 0.77%. And now I'm going to turn it over to Pari.
So I'm going to switch gears away from the fee schedule and do sort of a Medicare potpourri here. So the first thing I wanted to talk about was the Bipartisan Budget Act and the shift in the treatment of provider-based reimbursement. As I'm sure many of you know, historically off-campus hospital outpatient departments that met the definition of provider-based were eligible for payments under the OPPS. This resulted in relatively higher reimbursement than those departments than if they had been classified as clinics. This has been a topic of conversation for some years, and there's been concern from the government that this is not an efficient use of resources. It seems that CMS has pulled the trigger at least a little bit on this. So the change in the Budget Act, which functionally eliminates the provider-based designation for off-campus hospital departments that are newly created, is meant to partially offset the cost of Medicare premiums that would have otherwise increased. The CBO estimates this shift will generate over $9 billion in savings over 10 years. Under the new rule, hospital outpatient departments that are off campus falling within the scope of the amendment will be paid under the physician fee schedule or the ambulatory surgery center prospective payment system. So the scope of the rule is limited. It applies only to off-campus hospital outpatient departments, so not on-campus outpatient departments, and it excludes dedicated emergency rooms as those are defined under the EMTALA regulations. It also only applies to services or items that are furnished on or after January 1st of 2017. And then this is the big one, I think. It only applies to new off-campus hospital outpatient departments, which the statute defines as those that did not bill under the OPPS prior to the enactment of the statute in November of 2015. There's an error in the last bullet point on that slide. It should say those who did not bill. That's my fault. So there's a little bit of tricky timing here, given that the cutoff for the date of services to be furnished is different than the date of to identify grandfathered off-campus hospital outpatient departments. So you've got our permanently grandfathered category, so that would be an off-campus hospital outpatient department that billed under the OPPS prior to the enactment of this statute this November. They get to continue to bill under the OPPS. For those off-campus departments that are not yet billing or didn't bill under the OPPS prior to the statute, my read of the statute is they can bill under the OPPS until January of 2017, when they will have to convert to billing under the fee schedule or the ASC PPS. Off-campus hospital departments that begin operation after January 1st of 2017 will always be under the fee schedule or the ASC PPS and will not be permitted to bill under the OPPS, barring a statutory change. Out of the OPPS final rule, which CMS released in the end of October of this year, I'm going to talk about some changes to the 2 midnight rule. A little bit of background. Prior to 2003, Medicare Part A, or excuse me, 2013, Medicare Part A covered inpatient admissions when the physician expected the patient to stay for more than 24 hours. The government perceived this rule as being easily manipulated, so it adopted the 2 midnight rule and the 2014 inpatient prospective payment system rule, which came out in August of 2013. Under that rule, if a patient was expected to be in the hospital over 2 midnights, Part A coverage was presumed appropriate. If the patient was expected to stay less than 2 midnights, the hospital would be reimbursed under the OPPS instead, with pretty narrow exceptions. As explained by CMS at that time, the change was expected to result in some outpatient claims being treated as inpatient claims under the new rule, some inpatient claims being treated as outpatient claims. There's generally going to be a shift. And CMS estimated that it would result in net 40,000 more inpatient encounters, costing the government $220 million. To offset this anticipated cost, CMS reduced the inpatient rates. This is a bit of an aside, but I think it's interesting. As you may know, a group of Ohio hospitals sued, arguing that the rule was defective under several different administrative law theories. The theory that ended up having legs was that CMS had failed to explain its analysis of the fiscal impact of the new 2 midnight rule. which deprived commenters of the ability to meaningfully engage with the agency in the notice and comment process under the APA. This past September, so just a few months ago, the Federal District of DC sided with the plaintiff hospitals and granted summary judgment to those parties. The court declined to vacate the rule, but it did remand it back to CMS to explain themselves more thoroughly and solicit comments so that they could cure the procedural defect in the rule. CMS has left the cut in, but it did solicit comments in the December 1st Federal Register. So if you're interested in commenting on their methodology, which is admittedly a little wacky, the comments are due on February 2nd. Back to the actual change in the rule. The OPPS rule modifies the regulation to permit inpatient level reimbursement for a patient that a physician expects to stay less than 2 midnights in certain circumstances when the physician determines and documents in the medical record that an inpatient admission is reasonable and necessary. This change will be effective on January 1st of 2016. The rule and commentary don't give much detail on what criteria physicians are to apply to determine if inpatient admission is necessary in these sort of short stay settings. The commentary promises to provide more guidance about the medical review process. They'll be used in conjunction with the newly revised rule by the end of the year. With regard to short stays, which is where this new rule does its work, medical necessity for a short inpatient stay, so an inpatient stay for less than 2 midnights, must be supported by by documentation. CMS clarifies and reasserts its position, its historical position, that minor surgical procedures are not appropriate for inpatient admission and should be coded as outpatient even if they're provided overnight or the patient stays overnight. The rule does not disturb the treatment of procedures on the inpatient-only list or otherwise listed as a national exception. The commentary identifies new onset mechanical ventilation as an example of a procedure falling into that category. These short inpatient stays under the new regulation will be subject to medical review. That review will be conducted by quality improvement organizations rather than by the MAC or by RACs. Which probably, at least hypothetically, indicates sort of softer and kinder approach to enforcement here. The QIO is instructed to refer to midnight rule problems to the RAC if there are sort of signs of inappropriate use of the rule, so high denial rates, really high levels of exceptions to the general 2 midnight rule, or a failure to improve performance even after the quality improvement organization engages with the provider to improve documentation or whatever. For hospital inpatient stays expected to last more than 2 midnights, the rule has not changed. These 2 midnight plus stays are presumptively reimbursed under Part A, and they are not subject to medical review. Overall, I think this rule probably signals a swing away from mechanized rules and towards case-by-case physician judgment, although I'll note that even under the old 2 midnight rule, the appropriateness of inpatient admission was always based on the physician's expectation about the length of the stay. So in that way, the rule has always been about the physician's judgment. This new rule just sort of gives physicians more room to determine whether that 2 midnight is an appropriate benchmark for that particular patient. That's what I've got here, and I think we have a little bit of time for questions, unless anybody's got anything else. I think we have some questions to be addressed, right?
Got one question here. It's kind of a general question about payment for telehealth services. And the question is, if I use a normal telephone to diagnose and treat bronchitis, is that telehealth? What if I use FaceTime? Or does Medicare only pay for telehealth for limited reasons? So the answers are, I think, no and yes. No being, is a normal telephone call used to treat and diagnose bronchitis considered telehealth, not for Medicare reimbursement purposes. And with regard to Medicare only paying for limited reasons for telehealth, that's correct. There are a lot of very specific requirements that need to be met in order to bill and receive payment from Medicare for telehealth. And one of those requirements is that there has to be an interactive audio and visual telecommunication system in place so that the patient and the distance site practitioner can communicate via telehealth, and that's one of the key requirements for payment under Medicare. And also with regard to treatment of bronchitis specifically, as I mentioned earlier, there are a very specific and defined list of codes that are eligible for reimbursement by Medicare for telehealth services. So if you're going to bill for something, or if you want to try and offer services via telehealth between a practitioner and patient, not only do you have to make sure that those services are included in that list of codes, but you also have to make sure all of the other requirements are met in terms of where the patient is located, whether the patient's at an eligible originating site, whether it's located in the appropriate area, and also just kind of the additional Medicare requirements that are in place for telehealth. So it's not easy, and as I mentioned, the telehealth reimbursement requirements are dictated by statute in large part, so Medicare can only do so much.
Catherine, I'm going to be like David Glazer and ask you a question. With regard to FaceTime,
Yes.
FaceTime, presumably you're interacting with the patient visually and by talking. What do you think about that? I would think it might work, but that it also might raise some other issues such as data security and so on.
Yeah, I agree with that. There has been some limited kind of commentary from CMS about this. I know that there were services provided via FaceTime that CMS commented on and kind of said, it's something that we can consider moving forward, but they haven't released any specific guidance on whether FaceTime is appropriate in terms of an interactive audio and visual telecommunication system. I would think that that would meet the criteria under the statutes and regs, but like you said, it raises different issues that you would want to address, and I don't think a provider would necessarily look to FaceTime as the most appropriate mechanism for telehealth. There are a lot of other more protected systems in place that you could use that would deal with the kind of patient privacy issues that could arise.
I think there's one more on that page.
Let's see here. So if advanced care planning services is 14 minutes, do they pay? So Medicare payment under the codes that are billed for advanced care planning services, I believe that the two codes, the first code is for the first 30 minutes of advanced care planning services, and then there's an add-on code for the additional 30 minutes. So I don't believe I saw any specific commentary about the advanced care planning being provided that are in a duration of less than 30 minutes. So it's my understanding you would just use the preliminary code.
And I think we're not sure. I think that's a good question, and we will try to get back to you offline with the answer to that one. I think we don't have any more. I think we're right coming up to the hour, so we'll let everybody roll up their lunch bags and throw them away and head back to work. Thanks.
Thanks, everyone.